Welcome to the deep dive. We're your shortcut to getting instantly up to speed on, well, some pretty specific stuff.
And today it's really specific. We're diving into the foundational language for coding musculoskeletal treatments.
Yeah, think fractures, dislocations, tumor removals. If you're in this field, you know the difference between what you do clinically and how you have to report it. Well, it can be complicated.
Absolutely. So, our mission today, precision. We need to really unpack these definitions. What actually makes a treatment closed versus percutaneous? And for tumors, how does depth and, crucially, margin width define the surgery type for coding?
We're moving past the everyday descriptions into the nitty-gritty language the guidelines actually use.
Exactly. And before we jump into fractures, there are a few sort of ground rules we need to establish. These come up again and again.
Okay, lay them on us. What's rule number 1?
Rule 1 is about the first immobilization. So any musculoskeletal service code, it already includes applying and removing the first cast, the first splint, or the first traction device.
The first one. So the initial application is bundled in.
Right. The supplies, the plaster or fiberglass, that's usually reported separately.
Yeah.
But the act of putting it on and taking it off that first time included.
Okay. But what if things change? Swelling goes down, cast gets damaged, needs replacing.
Good question. Any subsequent replacements? A new cast, a different splint, new strapping, think codes 29,000 to 29750, or even replacing tractional at 2690, 2692 if that happens during or even after the global period.
That 90-day window usually.
Exactly. Those replacements can be reported separately.
And a key point you mentioned earlier, this initial casting or splinting, it's not pre-op care, right?
Correct. Absolutely not preoperative care.
Okay.
So modifier 56, for preoperative management only, you just wouldn't use it for putting on that first cast or splint.
Good distinction. Clears things up. What about grafts? Taking bone or tissue from the patient themselves?
Right. Autogenous grafts, bone, maybe tendon, fascia lata. If the surgeon needs to get that graft through a totally separate incision.
A different cut somewhere else.
Precisely. You only use the specific codes for harvesting that graft if the main procedure code description doesn't already say it includes getting the graft.
So it stops you billing twice for something that's considered part of the main job anyway.
You got it. Prevents unbundling, essentially.
Okay, foundational rule set. Let's pivot now to trauma fractures, dislocations. This is where, as you said, things can get really interesting, almost counterintuitive.
They really can. Because the absolute key thing to grasp here is there's no necessary link, for coding purposes, between the clinical type of fracture, like was it open, sticking through the skin, or closed, and the type of treatment code you use.
Wait, say that again. So a closed fracture might need open treatment coding?
Exactly. That's the disconnect you have to internalize. A patient comes in, skin intact, it's a clinically closed fracture. But maybe it's unstable, complex, if the surgeon has to surgically open the site to fix it properly.
Then you code it as open treatment.
Precisely. You code based on what the surgeon does, the intervention method, not the initial state of the injury.
Okay, that's a huge mental shift for some people. So let's break down those treatment types the guidelines define. Start with the most hands-on one, manipulation.
Right. Manipulation. The definition is pretty specific. It's achieving reduction, getting the bones lined up satisfactorily, only using manually applied force or maybe traction. It's the classic setting of a bone non-surgically.
Just hands basically are pulling.
Pretty much. But here's a nuance. Let's say the surgeon gets good alignment, but maybe 2 days later, things shift. The same doctor needs to remanipulate it.
What happens then? Is that included?
No, that's a distinct, separate service. You'd report the manipulation code again, but you absolutely must add modifier 76. That tells the payer, yes, this is a repeat procedure by the same person during the post-op period.
Modify 76 for the repeat. Good to know.
Okay, next up, traction. Sounds simple, just pulling, but there's a key difference in how you pull.
There is. Traction is just applying a distracting force, but we define 2 types based on where that force connects. Skin traction uses straps, boots, something applied just to the skin or limb surface. So nothing penetrates the skin deeply.
Correct, but skeletal traction is different. Here, a wire, a pin, maybe a screw or clamp, actually goes into or through the bone itself. That direct bone connection is what makes it skeletal.
That penetration is the defining feature. Okay, moving along the spectrum. Closed treatment. This term gets thrown around a lot. What does it technically mean?
Okay, closed treatment means the fracture site itself is not surgically opened. It's not exposed to the outside world, and the surgeon isn't looking directly at the bone fragments.
So no incision over the fracture.
Right, and this can be done without any manipulation, or with manipulation, or even using skin or skeletal traction we just talked about. They're all compatible with closed treatment.
But there's an important exclusion here, isn't there, about temporary stabilization?
Yes, crucially, if you just put on a cast or a splint simply to make the patient comfortable, maybe before definitive treatment is possible or decided, that initial temporary stabilization, that is not considered closed treatment for coding.
So slapping on a temporary splint in the ER doesn't automatically trigger the main fracture care code.
Exactly right. That's just stabilization, not definitive treatment yet.
Okay. Now for the one that seems to live in the middle, percutaneous skeletal fixation. Not quite open, not quite closed.
That's the perfect way to think about it. The guidelines literally say it's neither open nor closed. With percutaneous fixation, the surgeon isn't visualizing the fracture fragments directly.
No direct look at the break.
Right. But they are placing fixation hardware like pins or screws across the fracture site. This is usually done using X-ray guidance, like a C-arm or image intensifier.
So minimal incisions just big enough for the pins, guided by imaging.
Precisely. It achieves internal fixation without the need for a full open exposure.
And that brings us to the other end of the spectrum. Open treatment. This seems obvious, you open the patient up, but the definition is actually broader than just that.
It is surprisingly broad. So yes, open treatment definitely includes surgically opening the site right over the fracture or dislocation to expose it. That's the classic scenario.
Standard open reduction, internal fixation, or IF.
Right. But it also covers treating the fracture through the original traumatic wound, if there was one, or even extending that wound.
Okay, using the existing opening.
Yes. And here's the other key part. It also includes procedures where internal fixation, like a big intramedullary nail down the center of a long bone, is inserted through a surgical incision that's remote from the actual fracture site.
So the incision isn't right over the break.
Correct. And interestingly, for this specific scenario, remote insertion of fixation, like a nail, it counts as open treatment, whether the surgeon directly visualized the fracture site during the nailing or not. The remote surgical access for the implant makes it open.
That remote access point is key then. Okay,
Yeah.
that clarifies the main treatment types. Now, what about external fixation? Those frames on the outside, where do they fit in?
External fixation is a stabilization method. It uses pins or wires that definitely penetrate the bone.
So like skeletal traction in that sense.
Yes, they penetrate bone. But then these pins wires are connected outside the body to bars, clamps, rings forming a rigid external frame. It can be used temporarily or as the definitive long-term treatment.
And there are different types of these frames depending on complexity.
Yes, we differentiate based on the structure. Uniplanar means the pins are mostly in one geometric plane. Think pins going side to side through a bone, connected by a single bar. Maybe some triangulation across a joint, but still relatively simple.
Okay. And the more complex one.
That's multiplanar. This usually involves wires that go through the bone, transosseous, and threaded pins placed in several different planes. These are then connected to rings or half rings that encircle the limb. Much more complex, three-dimensional stability.
Like those circular frames you sometimes see. So if this external fixator is used, how is it reported? Can it be used with closed treatment? Open treatment?
It can be used with any of the primary treatment types, closed, percutaneous, or open. However, you only report the external fixation application code separately if putting on the fixator isn't already bundled into the description of the main fracture care code being used.
So check the main code first. If it doesn't mention external fixation, you can add the code for applying the frame.
Exactly. And one final reporting point for fractures and dislocations. If the doctor who does the initial treatment applies the cast, the surgery is not the one who's going to provide the follow-up care during that global period.
They're just doing the surgery and someone else manages recovery.
Right. Maybe transferring the patient back to their local doctor. In that case, the surgeon doing the initial procedure must append modifier 54 to their treatment code. It signals surgical care only.
Modifier 54 for surgical care only. Got it. Okay, that covers the trauma side, how we access and stabilize. Now, let's shift gears completely to tumor surgery. Here, the classification changes focus, doesn't it?
It absolutely does. With soft tissue and bone tumors, it's less about how you get there. Open versus closed doesn't really apply in the same way, and much more about how deep the tumor is and how wide a margin of normal tissue you need to take around it.
So depth and margin become the key classifiers. Let's start with the less aggressive types, usually for benign tumors, the non-radical excisions.
Okay, two main categories here, based purely on anatomical depth. First is excision of subcutaneous soft connective tissue tumors. Subcutaneous means below the skin, but critically, above the deep fascia.
That tough layer covering the muscles.
Exactly. So these tumors are in the fatty layer, essentially. The code includes simple or marginal resection. If the surgeon needs to do complex repairs, explore major vessels, or fix nerves, neuroplasty, those are coded separately.
Okay, below skin, above fascia. What's the next level down?
That's excision of fascial or subfascial soft tissue tumors. These are deeper, confined to tissue within or below the deep fascia, but, and this is important, they are not primarily involving the bone itself.
So maybe inside a muscle or between muscle layers?
Right, often intramuscular. Again, the basic dissection needed to get the tumor out is included, but complex repairs, vessel work, nerve work, those are extra.
You mentioned a specific point about fingers and toes, digits.
Yes, a fine point for clarity. For tumors in a digit, if it involves the tendons, the tendon sheaths, or the joint itself, it's considered subfacial. But if the tumor just touches or pushes against those structures, but doesn't actually invade or breach them,
Just sits next to them.
exactly, then it's still classified as subcutaneous for coding, even if it's quite deep in the digit. That invasion is the key.
That's a subtle but important distinction. Now, how do we pick the right code for these non-radical excisions? Is it just location?
No, for both subcutaneous and subfascial non-radical excisions, chord selection depends on two things: the anatomical location, arm, leg, trunk, etc., and the size of the tumor removed.
Size matters here. How is size measured? Just the tumor.
This is crucial. The size is measured as the greatest diameter of the tumor plus the narrowest margin of normal tissue the surgeon intended to take, and this measurement is taken at the time of excision.
Wow, okay. So the required margin gets added to the tumor diameter for coding purposes. A 2-centimeter tumor with a planned 0.5-centimeter margin all around gets coded based on 3 centimeters, 2 plus 0.5 plus 0.5, or diameter plus 2x narrowest margin. Wait, rereading the source. It says greatest diameter of the tumor plus the narrowest required margin. Let's stick to that wording. So a 2-centimeter tumor plus 0.5-centimeter narrowest margin equals 2.5 centimeters for coding size. Let me reread. Greatest diameter of the tumor plus the narrowest required margin. Okay, that's simpler than I thought. 2-centimeter tumor plus 0.5-centimeter margin equals 2.5 centimeter size for coding.
Exactly. That required margin can bump the coded size up significantly.
Definitely something to document clearly at the time of surgery. Okay, now let's move to the more aggressive procedures. Radical resection. This is usually for cancers or very aggressive benign tumors, right?
Correct. Radical resection implies taking out the tumor with wide margins of normal-appearing tissue around it, trying to ensure no microscopic disease is left behind.
So a much bigger chunk of tissue comes out. How is radical resection of soft connective tissue tumors coded? Still depth.
Not primarily depth anymore. For radical soft tissue resections, it involves taking those wide margins, and yes, it might involve removing tissue from multiple layers, subcutaneous, subfacial, but the coding, like the non-radical ones, is based on location AD size.
Size still matters for radical soft tissue. Same measurement rule. Tumor diameter plus required margin?
Yes, greatest diameter plus the narrowest required margin measured at the time of excision. Same principle, just usually aiming for wider margins.
Okay, now for the big one. Radical resection of bone tumors. Malignancy within the bone itself. What's the coding based on here?
This also involves taking wide margins of normal tissue, and it can be very extensive. Sometimes the entire bone, like the clavicle or fibula, might need to be removed if the tumor is large. Like other complex surgeries, any major reconstruction, vessel exploration, or neuroplasty needed is reported separately.
But how do we choose the primary code for the radical bone resection itself?
And here is the absolute critical difference. For radical resection of bone tumors, the code selection is based solely on the location of the tumor. Which bone is involved? Femur, humerus, pelvis. That's it.
Wait, so the size of the bone tumor doesn't matter for picking the code? Whether it's benign or malignant doesn't matter,
Right.
primary or metastatic doesn't matter.
Correct. For the radical bone resection code itself, size is irrelevant. Benign, malignant, irrelevant. Primary, metastatic, irrelevant. Only the anatomical location dictates the code choice.
That is fundamentally different from soft tissue tumors, where size is a key component for both non-radical and radical coding.
A massive difference. It trips people up all the time. Soft tissue, location A and D size, plus margin. Radical bone, location only.
Okay, one more clarification. If you're doing a radical resection of a bone tumor, You're often taking surrounding muscle and soft tissue as part of that wide margin. Do you code that soft tissue removal separately using the radical soft tissue codes?
No, you do not. If the surrounding soft tissue is removed as part of the radical bone tumor resection to achieve those necessary wide margins, you should not report the radical soft tissue tumor codes separately. It's considered integral to the bone procedure.
Bundled in. Got it. Wow, we've covered a lot of very precise ground today.
We really have.
Yeah.
From how we classify fracture treatment based on the surgeon's access,
Mm-hmm.
closed, percutaneous, open, all the way to how tumor removal shifts focus to anatomical depth, and critically, margin width for soft tissue, but then flips to location only for radical bone surgery.
It really underscores how these guidelines create their own specific language. Which leaves us with a final thought for you, our listeners, to chew on. That fascinating disconnect we uncovered. Why is the size plus margin so critical for coding radical soft tissue removal, but completely irrelevant for radical bone removal, where only location matters?
It highlights that these aren't just descriptions of surgery, they're a specific coding language. Understanding that language down to measuring margins at the exact moment of excision is absolutely key.
Something to think about next time you encounter these scenarios. Thanks for joining us on this deep dive.
We'll catch you next time.